Hello and welcome to Pulse Check with Archer Nursing, where nursing comes to life. In this podcast, you give us 15 minutes of your day, and we'll take one complicated nursing topic and make it easy. Ready for nursing to be fun? I'm Morgan, and today we're tackling polycythemia and polycythemia vera. So before we jump into the specifics, let's start off with our practice question. The nurse is assessing a client with polycythemia vera. Which client finding requires the nurse's immediate intervention? We have A, reports of blurry vision and ringing in the ears, B, complaints of dizziness when standing up quickly, C, noted splenomegaly on abdominal palpation, or D, the sudden onset of right-sided weakness and slurred speech. Okay, so tuck your answer away, think about it for a little bit, and we will circle back to the correct answer and why at the end of the episode. First off, though, what the heck is polycythemia? I'm going to start off here, polycythemia vera, or PV. This is a bone marrow disorder that causes the body to produce way too many red blood cells. And not just red blood cells. It often also ramps up the production of white blood cells and platelets. Now, that's because PV is what we call a myeloproliferative, which just means it's a problem of uncontrolled growth, and it starts in the bone marrow. The bone marrow is where we make all of our blood cells, so then we make way too many of them. Too many blood cells means that the blood becomes thick, sticky, and therefore hard to move through the body. Imagine you're like trying to force honey through a straw instead of water. That's what your hearts and blood vessels are dealing with when you've got PV and you're making way too many blood cells. All right, now before we go on though, let's pause and clarify the difference between just polycythemia and the polycythemia vera. If you hear your client has polycythemia, it simply means an abnormally high concentration of red blood cells, not all the other stuff that we saw with polycythemia vera. And polycythemia can happen for a ton of different reasons. Think about the body is trying to compensate. It's like, I'm not getting enough oxygen, so I'm going to make more red blood cells. That could be a response to somebody living at high altitude, having chronic lung disease, experiencing long-term hypoxia. Maybe it's sleep apnea. Whatever reason, low oxygen, the body says, I got to fix that. I'm going to make me some more red blood cells. We get too many. And this is polycythemia. That's a secondary polycythemia because the bone marrow is reacting appropriately to the body's demand for more oxygen. Now, in contrast, if we have polycythemia vera, that's a primary disorder. The bone marrow itself is the problem. It's churning out too many cells, from red blood cells to white blood cells to platelets, without any actual trigger from the body. So both conditions involve too many red blood cells. Polycythemia vera makes too many of all the blood cells, and it is driven by a genetic mutation. This mutation, often it's a gene called JAK2, JAK2. And there's just one tiny change in that gene that causes the huge problem. Essentially, it turns on a signal that then tells the bone marrow, hey, just keep making cells. Even though the body doesn't need these RBCs, make them. Make more platelets over there. Make those white blood cells. It's like a broken thermostat. It keeps telling the furnace to run even though the house is boiling hot. And over time, that bone marrow just keeps pumping out more and more. So this makes the blood thicker than normal. Remember, honey going through a straw instead of water. It doesn't flow easily, and less oxygen gets delivered to the tissue where it needs to go. So symptom-wise, the body starts to feel that low oxygen. Primary classic first symptom, fatigue. Their brain's not getting enough oxygen, they're tired. They get dizzy, they have headaches, they might have blurry vision or ringing in the ears. There is one really specific and strange symptom, itching after a hot shower. There is actually a funny name for this, or a fancy name that I think is funny, aquagenic pruritus. So we have the water, the hot shower, and then we're itchy, the pruritus. It happens because of the overactive basophils. We've got so many basophils. We get in that hot shower and then they release histamine and we feel itchy. All right. Another symptom with a fancy little name, erythromelalgia. This is a burning, painful redness that happens in the hands or feet because of microvascular blockages in those tiny little vessels. This isn't just like discomfort. This is thick, sluggish blood raising the risk of clots and causing really painful redness in the hands and feet. Now, I just called out what is the key takeaway of this episode: clots. We have to watch out for serious issues due to clots. This blood is hypercoagulable. It could cause a clot to go into the blood vessels and have a DVT. It could cause a clot to go to the heart and we could have an MI. It could cause a clot to go to the brain and we could have a stroke. Okay? And don't forget the spleen. We could have extra traffic going there, causing splenomegaly, and then that can cause some abdominal discomfort. Okay, so recapping here. How does this anatomy tie to the symptoms? With polycythemia, our body's responding to low oxygen and making too many red blood cells. With polycythemia vera, we've got a genetic mutation. Our bone marrow is churning out too many blood cells, RBCs, WBCs, and platelets. Both of these diseases, they cause thick, honey-like, clogged up blood. It's just really hard to flow when we've got that really thick blood, and that clogs up our vessels. That leads to fatigue, dizziness, headaches, that aquagenic pruritus, that itching after a hot shower, and really just decreases oxygen delivery out to all our cells. All right, now I have not had a client with polycythemia or polycythemia vera. So here as our first guest on Pulse Check today, we have our very own Rebecca Coulter to talk to us about a very close case of polycythemia to her. Welcome to the podcast, Rebecca.
Hi, Morgan. Thank you so much. Excited to be here.
Yeah, we're so excited to have you here. It's going to be awesome. So tell the audience a little bit about yourself, who you are, and then let's jump into your polycythemia story.
Yeah, sure. So, hi, everyone. My name's Rebecca. I have been an ICU nurse since I graduated nursing school. I've worked all over the country and landed out here in Montana and love anything critical care, and also have not seen a ton of polycythemia in practice. I think there was one case maybe, but my connection to it is my dad has polycythemia and he was diagnosed with that a few years ago. And it was something I remember the phone call, and he called me and was like, "So I've got this thing." And I was like, "What the heck?
What
Of
do you
all
mean?
things, you have polycythemia?"
Right.
Like, that is so strange. But how he kind of came around to understanding that he even had polycythemia was, I think his first symptom would be fatigue, which
Okay.
is a classic symptom of polycythemia. So he was just could really tell he was not getting around as well, taking more naps during the day, couldn't walk as long distances. He does have other past medical history things that he could kind of chalk things up to, but it was
Gotcha.
abnormal for him.
Okay.
So he went in, and right around the same time, he was diagnosed with CLL, so chronic lymphocytic leukemia. And while they were doing blood work for that, they noticed that his hematocrit was over 60. And that
Over
was
60. So,
over
like,
60.
over half of his blood was red blood cells.
Yes. Yeah, totally. So they were like, well, that's kind of a red flag. Something else is probably going on, and that would
Something's
not
going
be
on here.
related. Yeah. And they determined that was not related to the CLL that they
Got
were
it.
in the process of kind of working up. So kind of
Yeah,
got
because
multiple.
usually when you think about leukemia, you think about low blood cell counts. You're like, low platelets, they're going to bleed. Low red blood cells, they're anemic. But this was the total opposite.
Yes, totally. And for him, when he first got diagnosed, it seemed like, if I remember correctly, that it was just his red blood cells, hemoglobin, hematocrit that were elevated. He didn't have
Okay.
other elevations. It sounds like now his white blood cells have been a little bit more elevated, which is
Oh,
funny given the
interesting.
CLL. But I think the CLL stays pretty dormant all the time. It's a pretty low risk, technically, obviously, a cancer, but really,
Mhm.
really low risk. So his
Okay.
polycythemia is actually more acute than his cancer diagnosis. So yeah, they saw this really high hematocrit. Hematocrit's definitely the thing they care the most about with assessing how thick the blood is and that sort of thing.
Yeah.
So they started to do some testing to figure out what exactly could be the cause for my dad having this condition. And there is a mutation that can cause it, the JAK2 mutation. And that's what's usually heavily associated with polycythemia vera. He was
Right.
negative for that mutation. So they determined he didn't have the vera form of
Okay.
polycythemia.
And
So
that's
once
when
they
we have all of our blood counts going up, platelets, white blood cells, and RBCs all going up due to this genetic component, this mutation of that JAK2. Versus in polycythemia, we're just seeing the RBCs go up, driving that elevated hematocrit, making our blood thick and sticky and hard to get to the places it needs to go.
Totally. Yes, absolutely. And that mutation acts in the bone marrow. And that's why they
Okay.
see that increase in all the different types of
Yeah.
blood cells. So he didn't have that. So then you've got to figure out, well, why is the body creating all of these extra red blood cells? And you go through like a natural progression of thinking through, well, what is the body trying to compensate for if it's trying to kick out all of these red blood cells? So there are some causes out there that do kind of make sense. Things like sleep apnea, if you chronically either visit high altitude locations or live somewhere high altitude that you maybe your body never got accustomed to it, that could be a reason. A kidney tumor could be a reason, as it would cause excessive erythropoietin production. So
Okay.
there's all these various causes out there, and my dad was diagnosed, I want to say 3 years ago, and we actually still don't know what his exact cause is.
Oh, they still haven't run down exactly what's like making his body go into overdrive, producing
Right.
all these red blood cells. Crazy.
Yes, totally. So I don't know if, I mean, I think there's an idiopathic form for everything. So he would
Uh-huh.
probably maybe fall in that category. Like I said, he's got other diagnoses as well, pretty standard hypertension, diabetes
Yeah.
that usually don't end with this sort of diagnosis. So it's still a bit of a mystery. He went through the sleep study to see if he had
Okay.
sleep apnea. All
Sleep
of that was
apnea.
fine. But yeah, so a bit of a mystery. So now he's just in the management phase of
Okay.
polycythemia. Yeah.
Yes. And this is what I wanted to ask you about. So we've got this thick blood, hematocrit of 60% wild. Obviously, that is going to make his blood sluggish. It's going to be just like harder for the heart to pump all of that thick blood out to his organs. So I'm thinking like lack of oxygen to all of his tissues can be a problem. It sounds like he potentially could clot more easily with that thicker blood, as well as probably put a lot of pressure on his heart. That sounds like combined with the hypertension, a lot of afterload going on for that left ventricle to pump against. So, what treatment happens, like mitigating those different complications? Where is he at now? Is his hematocrit still 60?
Oh my goodness. Absolutely not. I don't think they, once they find out that your hematocrit is 60, they don't
They're
want
like,
you to
no.
do that. Yes.
Thank
Because
goodness.
of all of the things that you talked about, the oxygen delivery, the clotting risk, sluggish blood. The oxygen delivery is such a funny thing. You think that, oh my gosh, I've got so much hemoglobin, so many red blood cells. Wouldn't my oxygenation be so good? And it's just not because of that sluggish blood. So, yeah, super good point. So, for him, his main treatment, which is obviously symptom management, is phlebotomy to kind of do
Wow.
blood letting, so to speak, of just take blood out like you're giving a blood
Wow.
transfusion, except they aren't going to give his blood to anybody, but remove blood and that will
Remove
hematocrit.
red blood cells. Yeah. You're
Sometimes,
just
or yeah, remove,
the
yes,
reverse of a transfusion is you're just
yeah,
taking the blood out.
you just take it out.
We've got
And
too much,
sometimes
we
it's
take it
paired
out.
with, right, exactly. Sometimes it's paired with giving some fluid so that one, he tolerates the phlebotomy service better and also can just further dilute the blood,
Dilute
at
those
least
cells.
temporarily.
Okay.
Right. So yes, he does checks. He gets checked every 3 months. They check his hemoglobin and hematocrit. Again, the main number that they're really tracking and treating for is that hematocrit percentage. And he's kind of moved around to a couple different doctors. So his goals have changed recently. It used to be that they wanted his hematocrit to be under 51, which would put him in the normal value for a male hematocrit. Now he's with a doctor that's actually okay with him being as high as 59.
Oh,
Um,
big difference.
is
Okay.
interesting. Yes, I don't know. I don't think he's gotten that high yet to see like if they would intervene
Uh-huh.
before that point. Right now, I think he's sitting around 52% and didn't have to have phlebotomy done for that. But sometimes he'll call them before that 3-month mark and say, I'm not feeling great. He can kind of
Gotcha.
tell,
Can tell.
and will go in and do it sooner. So that's his main treatment. There are, if you've got the polycythemia vera, there's other cancer medications that you can receive as a treatment for that. But because he doesn't have that mutation, he is not on any of those.
Okay. All right. And then along with the bloodletting, the diluting of that blood so he's got better perfusion and whatnot, are there certain things like lifestyle modifications, things he needs to watch out for, signs and symptoms of complication that you guys talk about, any of that stuff?
Not a ton, really. Maybe we should talk about it more. But I think he,
Shouldn't we all?
like, if I was being like a good nurse daughter for him, I would give him this to-do list of things to look at. But for the most part, I think they want him to, pay close attention to stroke symptoms, pay close attention to DVT symptoms, staying active and mobile, like all of like the
Okay.
general recommendations for overall health, I think are good ones for polycythemia. And then I think for like specific risk factors, that fatigue is a good one, especially if that's like, I say this for a lot of different conditions. Whatever your presenting symptom is that told you maybe something's going
Yeah.
on, you kind of know that that's how your body's going to tell you that something's going on. It's a reliable thing to look at. So he kind of knows, if he's feeling tired, there might be something going on oxygenation wise. But yeah, just clot risk concerns. His platelets are fine. I think I just talked to him about all of his numbers, so I feel well
You've
informed.
checked in. You've fulfilled your nurse daughter duties.
Yes.
Dad's labs have been reviewed.
Yeah, exactly.
Good. No, that makes sense with monitoring for, a DVT, being really cautious of if there's any sort of symptom that could indicate a stroke, just knowing that you've got all those extra blood cells, if they are or are not platelets, it's still going to put you in that hypercoagulable. So being aware of that clotting makes a lot of sense. Well, thank you for coming on to walk us through a case of polycythemia.
Absolutely. Thank you for having me.
So now that we've gone through our case, let's circle it on back to that practice question and see if you can get to the right answer and why. You're the nurse assessing a client with polycythemia vera. Which client finding requires the nurse's immediate attention? We had A, reports of blurry vision and ringing in the ears. B, complaints of dizziness when standing up quickly. C, noted splenomegaly on abdominal palpation. And D, the sudden onset of right-sided weakness with slurred speech. Alrighty, write it down, say it out loud with me. What is the symptom that raises our red flag in a client with polycythemia vera? It's D, right? That sudden onset of right-sided weakness and slurred speech. That sign makes me think stroke. And clients with polycythemia vera are at very high risk for thrombotic events due to the hyperviscosity of their blood, plus, in vera, increased platelet activity. So when we see neuro changes like right-sided weakness and slurred speech, that possibility of a stroke requires immediate intervention. Our other symptoms, blurry vision, ringing in the ear, dizziness, splenomegaly, these are possible things that we will see with polycythemia vera. They can all be explained by that hyperviscous blood, that honey trying to go through a straw instead of water. But they are expected findings. Now, we still want to do something about them. Remember our treatment, bloodletting, phlebotomy, trying to actually reduce the viscosity of that blood. But they don't raise the red flag for a stroke like that sudden onset right side weakness and slurred speech does. So remember, key takeaway, polycythemia and polycythemia vera, two different ways that we end up with really thick blood, that hyperviscous blood. That's going to put us at risk of clots. We're going to watch really close for those signs and symptoms that could indicate a coagulation emergency like a stroke. All right, future nurses, that is a wrap. If you found this pod helpful, I'd love to continue supporting your nursing journey through nursing school, the NCLEX, continuing ed, and beyond. Archer Nursing has you covered with on-demand video lectures, high-yield question banks, live case study reviews, and so much more. We want to help you master tough concepts and make it fun. So join us over at archerreview.com. Follow us on socials at Archer Nursing for more free nursing tips and study resources. Thanks for tuning in to Pulse Check with Archer Nursing. I'm Dr. Morgan Taylor, and I'll see you back next time.